It's such a pleasure to be here, and I'm sorry that you were not able to have Dr. Resnick, but sometimes things work out for me. So it's a pleasure to be here. I did live in Nashville for 9 years. If any of you walked by the Symphony Center, which is just a block over, that's where my husband and I got married. So it's always fun to come back home and see old things, new friends, old friends, and the like. So. And it's also fun just to be a part of this kind of new annual meeting format, and I'm certainly very much looking forward to providing some remarks, helping with the installation, and having a new partner as I take on my role at the end of the week in Chicago next week. So I thought I would make some comments about what's happening at a broad level across the AMA. And let me just preface this by saying that this is a really hard time to be in healthcare or just to be a physician. And there are some really powerful forces that are at work, working to strip away a lot of autonomy that both patients and physicians have enjoyed for a very long time. There are ongoing efforts in many states, including, unfortunately, here in Tennessee, to criminalize healthcare that we know is appropriate and evidence-based. On top of that, of course, medical technology is just getting more and more complex by the day. I know many of you have heard of things like AI and ChatGPT, and what that will do for the delivery system, I think, is an open question. But we know that there are rapid changes happening across all of the environments that we practice in. And while the worst of COVID, I think, is behind us, we still have 150 Americans dying every day from the disease. And physicians just are under enormous pressure in every corner of the country. And unfortunately, burnout is commonplace. It is a daily occurrence. So all of this to say, the work that you all do as an alliance, your support for physician families has never been more important. You are our partners, you are our sounding boards, trusted confidence, and our allies in medicine, and I cannot thank you enough for everything that you do, really, I mean that. The truth is that physicians could not hope to fulfill the mission of the AMA without the work that you all do as an alliance. Not only work out in the field to certainly promote and advocate for strong communities and families, but the emotional support that you all give to us, especially over what has been just an unbelievably challenging last couple of years. Your support has just been so critically important to the House of Medicine. So today is a very special day when we are going to swear in a new Alliance president. Again, congratulations, Rachel. But first, I want to give you an overview of some of the most pressing advocacy issues that the AMA is working on and highlight some progress that we've made. So that's a lot to do, and I think I was given 30 minutes, so I'll try to stick to time. Okay, so this is my 76-page CV boiled down to one slide. It is available, however, for download on request. So if anybody wants it, we can send the PDF over. I did spend 9 years here on the faculty at Vanderbilt. I still have adjunct appointments here, which confuses everybody because everybody thinks I still live in Nashville, but I live in Wisconsin with my husband, where I work at the Medical College of Wisconsin primarily, but I'm down here occasionally from time to time. A lot of wonderful experiences along the way in the digital health space, mostly right now in the sort of standards terminology land, trying to make sure that we've got the right standards, terminology, regulatory framework for all of these digital tools that are coming at us. So that is me. And I will just make mention of the fact that, you know, the Alliance has always had a very special place in my heart. And I still remember 2013, I think it was, Joe Terry, when you were the Alliance president. And we had a lot of fun as partners when I was down here in Tennessee and you were in that role. And I have to tell you, these are organizations with a long legacy. 101st annual meeting, is that what I heard? And AMA is now 176 years old, and both organizations have evolved. And when I was a medical student, the organization was an organization for spouses. It was not an organization for partners or same-sex couples, and that changed. And that was a wonderful change, an important change, and I think has been an important step along the way as you have become a more inclusive, broader organization that can support all kinds of physician families. So I just want to make mention of that. So as I think about the present and the future of medicine, we have tremendous challenges that we are trying to confront today, and we're going to have to confront in the future. All of business, all of healthcare is getting digitized, and that is having all sorts of very funny effects for the delivery system. We've got a continued rise in chronic disease. Half of the people living in my home state now of Wisconsin have hypertension, but only half of them are controlled. And it's not because we don't have pills that work. It's not because we need a new fancy molecule or therapeutic drug to solve the problem. They're delivery system issues, and we all know that. We obviously have just been through COVID. Who knows what's ahead for major public health events? We've got tremendous pressure on the healthcare system because of the demographics and aging population. We've got increasing needs to meet diverse patients' communities where they are, which we have often failed to do. And then, of course, there's AI, and what does that mean? So this is what makes the work of organized medicine so important. We need physicians, an ally on our side, and that's exactly what physicians get from both the AMA and the AMA Alliance. Now, you no doubt have seen before that all of the AMA's activities, and we've got about 1,200 folks who show up every day rolling up their sleeves on behalf of physicians, all of that work is really organized into 3 buckets. Getting rid of the obstacles that interfere with us taking care of patients and suck the joy out of the practice of medicine sometimes. Improving the health of the nation by leading the charge around chronic disease and public health crises, and driving the future of medicine by reimagining medical education, training, lifelong learning. This is the work we do every day to improve our practices, elevate our concerns on the issues that matter most to us and our patients. So, closer look at a couple of those areas. We always will put the needs of our patients first. Even that means when we have to put our needs and ourselves at greatest risk. And I still remember walking into my hospital in March and April of 2020 being very afraid because we didn't really know a whole lot about COVID. We knew it was here. We were watching these case numbers rise. We weren't sure how to deal with it, how to keep ourselves safe, our patients safe, and our families. And that's been really hard. And that being said, when the nation needed us, we were there. And we continue to be there for our patients today. What are we asking for in return? Well, we are asking that our nation reaffirm its commitment to us. And that is our AMA recovery plan for America's physicians, to create the change needed to make a sustainable healthcare system that better supports patients and physicians over the long run. This was launched a year ago. It's confusing because Dr. Harmon announced it. Dr. Resnick has carried it through this year, and I get to be guy number 3. But it's only been around for a year. 5-point plan, again, the QR code will tell you all about it. Reforming Medicare payment to make sure that we have practices that thrive, that we can actually support innovation at the practice level. Fixing prior authorization, getting rid of the obstacles and the hoops that get in the way of our patients needing care. And I'm an anesthesiologist. I never see a patient where it was easy for them to get approved by their insurance carrier to come in and have surgery. It just doesn't happen. It's just how many obstacles, how many phone calls, how many faxes, how many denials did they have before they got to see me. Ensuring physician-led team-based care to support safety, reducing physician burnout, and then obviously supporting telehealth. So each of these objectives is within our grasp. If we achieve them all, we will streamline healthcare delivery. We will improve patient care. We will support innovation while allowing us to more effectively respond to whatever lies ahead. So let me tackle a few of them. On the payment reform side, There are lots of different issues that can jeopardize patient care in different ways. But one issue that's been a major focus of advocacy for the AMA in recent years and continues this year and in the year ahead is sounding the alarm on what is truly an unsustainable, irrational Medicare physician payment system. It's not just about how much money is coming to physicians. It's about building a sustainable healthcare model that supports physicians, particularly our colleagues in private practice who face tremendous financial pressures. The current Medicare payment model threatens practice sustainability because we have not had a meaningful physician payment increase in, wait for it, 20 years. Think about that. It's shocking just to say that, considering how, practice costs have kind of gone up, particularly this year. High inflation, it's been 20 years. If you adjust for inflation and practice costs, Medicare reimbursement has dropped 26% between 2001 and 2023, a 26% relative drop. So what happens if you don't have the resources to keep the lights on? Well, people stop taking care of seniors. And this happened to my parents. Their doctor down in Jacksonville, Florida said, we can't do it anymore. And then they're stuck trying to transfer all of their care, and my parents are in their 70s. They have a few health problems, a couple of complex things, and it's not straightforward. And then care gets transitioned, things get lost, and a lot of stuff gets repeated. And it's harder, and now, of course, they're traveling farther away to see a doctor who's not as convenient as the one that they had. So, it's true, we were successful this past year in getting an end-of-the-year limit to the planned reductions. It was only 2%. It was going to be 8%. But the fact that we have to do this year after year after year, it's like Groundhog Day on a hamster wheel, hoping for a last-minute deal to avoid a financial calamity is ridiculous. So we need to get real Medicare payment reform. And the good news is we are finally starting to see a little bit of action. There's a glimmer of hope. So Congress took an incredible step forward. There's a bill, HR 2474. This aligns the Medicare fee schedule with the Medicare Economic Index, which is a move we have long supported. It is basically an inflationary adjuster. So this would allow physicians to be on the same playing field as everybody else in healthcare by having payment adjustments tied to a rate of inflation. So we're hoping that we can get there. If you are not a part of our Physicians Action Network to help us contact our legislatures, please join. Tell all of your friends to join. We are working office by office. This is hand-to-hand combat. To make sure that the light bulbs go off in Congress and people understand that they just have got to fix this. All right, prior authorization. We have survey data after survey data point after survey data point that shows how bad it is. 94% of doctors say that prior authorization causes care delays. 80% say that patients just give up. They don't bother trying to get their colonoscopy. They don't bother trying to get their preventive screening. They don't bother trying to get surgery that's necessary. A third of physicians tell us that prior authorization has led to a specific harmful adverse event in a patient. Not hard to imagine when a drug is refused to be covered or someone has to go through step therapy trying a medication that we know doesn't work because we already tried it. But maybe they changed carriers and now this new carrier wants them to try it again. We all understand the burden that this places on practices. The average practice, it takes 2 days a week of staff time for the average physician to support all of the back and forth with the insurance companies. So there's a critical need to streamline things. What have we done? We've had a national approach, multifaceted approach. We have brought together a lot of research, a lot of resources. We convened a whole bunch of states and specialties. We brought in the national payers. We brought in patient representatives, patient advocates. We have a whole list of best practices for prior authorization. Guess what? Completely ignored by every third-party payer. Unfortunately, they just have said, that's nice, but we're not going to do it. So the only other option we have is to get regulatory relief. And so we have finally gotten a little bit of a break. And CMS has brought forward a regulation that's going to right-size prior authorization in Medicare Advantage plans by ensuring continuity of care, making sure that there are clinical coverage criteria that are clear, transparency around what's happening, and some work to put timelines around all these things. So we are working to get this finalized, and this is going to require, again, all government health plans, primarily Medicare Advantage, to have electronic prior authorization, so it gets rid of the faxing back and forth and the phone calls. Publicly report how often are they denying care. Those statistics are very hard to get right now and require certain processing time to happen. So we're going to make sure that this moves forward in the 118th Congress so that we can get these prior authorization reforms to debate. And I'm really excited about this. There's a parallel sort of work happening in many, many states. We've had 7 states now pass similar approaches at the state level. Again, the CMS stuff is only for Medicare, but there's obviously a need across all of the plans. So again, if you're interested in helping us with that, fixpriorauth.org is the website. All right. Next topic I want to mention is burnout. And this is close to all of us. We know that weaknesses in our healthcare system that became increasingly apparent during COVID amplified a largely unrecognized, unacted on lack of support for physician wellness. And there's a very alarming Mayo Clinic study at the end of last year showed that physician burnout has spiked to a record high that we have never seen recorded in a survey before. 63% of all physicians nationally in a nationally represented sample have symptoms or experiencing burnout. 63%. That's 2 out of 3 physicians are experiencing burnout. That is a true crisis. That was followed by another Mayo Clinic study that found that 1 in 5 doctors and twice as many nurses, it's not just doctors, said that they plan to just give up and leave the profession in the next 2 years. And many, many more said that they're going to cut back their hours. So if only a portion of people follow through on that, think about what that does to access across the country to healthcare. It's staggering. Potentially devastating if we have another COVID-like public health emergency and all of those people are no longer in the workforce. So while burnout contributes to the problem, we know solutions have to go beyond administrative simplification. We've got to also establish support systems to empower physicians to get the help that they need without fearing a negative impact on their careers. So we continue to push for legislative solutions. We need more funding. We need more resources to support mental health of physicians. We're working with state licensure bodies to get rid of questions on licensing forms that might deter somebody from getting the help that they need. And we've worked with the Federation of State Medical Boards, the Federation of State Physician Health Programs, to support confidentiality and safe haven laws around physician wellness programs. And so all of these things are really, really important because there is so much stigma around getting behavioral health support. Now, following the passage of the Dr. Lorna Breen Healthcare Provider Act last year that was signed by the President, a bill which the AMA very, very strongly supported, we continue to look for more action. Again, stigmatizing language on a credentialing application for a hospital or a licensure application for a medical board has to go away. And so we're getting rid of these questions about past diagnosis. If somebody went to a therapist in high school, that should not hold up their state license for 9 months, and that has happened. It happened to a friend of mine. And what does that make one do? Well, it makes one want to not be honest or to not go to therapy, and that's just not appropriate. So we're starting to get some movement on this. Not all states have taken the actions that we've requested, but I think there's a growing consensus that it is the right thing to do. Now, I want to spend just a few minutes talking about how we are defending patients and physicians in the courts. And there was mention earlier of a pending Supreme Court case. That case is around, there are actually 2 cases around race, the use of race in higher education admissions, which will potentially have a profound impact on who gets into college in who gets into medical school. And we'll see how that lands. My guess is it's going to happen at the end of June. Lucky me. And we'll have to figure out how to respond. But I want to highlight just one specific case because it sort of shows the stakes and the broader implications for healthcare. So we filed a lot of amicus briefs in a lot of high-profile cases. We strongly believe, and this is a cross-cutting principle that is not new. It is not just something that we thought up this past year, that decisions about a person's health should be between them and their doctor. It's a pretty straightforward concept. My husband will tell you there is nothing more irritating than a backseat driver. We got a lot of backseat drivers in medicine interfering with how we practice. And unfortunately, a lot of that are lawmakers and legislatures. So we stood up for patient and physician autonomy in the Dobbs versus Jackson Women's Health Organization case. Unfortunately, that did not go our way. And now 20 states have banned or partially banned abortion and other reproductive care for patients. I will tell you, that is having a cascading impact on all of women's health. Because in my state, we had a huge drop in the number of medical students who want to do residency because of that. 10% drop in applications for residency. And I'm seeing my colleagues make the hard decision but to leave. And colleagues who didn't do a whole lot of abortion care, but did a whole lot of women's health care, and are no longer doing that women's health care in these states. So it's getting bad. Similarly, we have filed amicus briefs in cases to protect access to the drug mifepristone. And while the U.S. Supreme Court granted a stay, it halted the lower court's ruling to ban use of this long-time drug. This case is going to go forward to the Supreme Court. And so the case, what's happened is a couple of anti-abortion organizations and physicians who have never prescribed the pill, by the way, absurdly, are arguing that 23 years ago, the FDA did not follow the right protocol when it approved it as a part of a 2-drug regimen for abortion. So the view that we have is that this case represents the most brazen attack yet against reproductive health in our country, but the outcome has profound implications beyond the abortion issue. The outcome could upend the entire regulatory framework for the FDA, which could throw our healthcare system into chaos. So in ways that would get much, much farther beyond the very specific case related to mifepristone, which is a highly safe, effective drug used by millions of patients safely. If the Supreme Court upholds any piece of this district court's very dangerous ruling, what would likely immediately happen would be challenges to other longstanding, safe, effective medications that we rely on every day. So unfortunately, after 3 years of misinformation, disinformation, bad information, whatever words you want to use around vaccines and COVID, surely there will be challenges to vaccine approval, guaranteed. We should expect lawsuits against common types of safe, highly effective hormone birth control, including emergency contraception, drugs used to treat cancer and arthritis that can incidentally affect unexpected pregnancies, drugs to prevent HIV, medications aimed at providing gender-affirming care. All of those things will be instantly targeted if this ruling stands. So there is a lot at stake in this one case that is about one drug. It is much, much broader, the implications. Okay, so I'm running out of time, but I want to just make a few mention of some of the ways that we're working to improve public health. So I was here in Nashville in March. I flew down to speak at Vive Health, which is a tech conference, the day of a horrific school shooting about 3 miles down the road. And one of my physician colleagues lost their child in that shooting. A second physician who I don't know also lost a child. My former resident was in the classroom where most of the deaths happened an hour beforehand because she does a lot of global health work. and had been invited in to talk to the kids about doing anesthesia overseas. And as she was driving away, started to hear news on the radio and felt at a complete loss, guilty. Why wasn't I there to do something? I had just left. We see this devastation of firearm violence up close. It's in our emergency rooms. It's when we have to tell families that we can't save somebody. The most loud, most piercing scream I have ever heard in my life, which is forever imprinted on my eardrum, was a mom when I had to tell her that her son was killed. And I'll never forget it. So what do we do? It's easy to just gloss over these things like it's an everyday occurrence that we can't do anything about. But there is a lot we can do about it. And there's a lot that we can do as physicians and physician families through our organizations to prevent gun violence from killing innocent people, especially on kids. And I tell you, I drop my son Ethan off. He's 4 years old at school pretty often when I'm home. And going to school should be a pretty routine, safe place for him to be. But he is more likely to die from a gunshot than anything else. That is the number one reason that a child or teenager dies in America today. It used to be car accidents. It's not anymore. And I tell you, cars aren't that much safer than they were 3 years ago. It's the gun violence. So we've continued to call for reform. In 2016, after the Pulse nightclub shooting in Orlando, we declared gun violence a public health crisis. But unfortunately, injuries and deaths have only gone up. And there's an urgent need to better understand what is the root cause so that we can develop the science, implement evidence-based strategies. And our own advocacy efforts on gun violence have widespread support by the American public. Poll after poll after poll shows you that in every state in the nation, does not matter what color the state is, people support these things: banning assault weapons, high-capacity magazines. I spent 10 years in the Navy. In fact, I earned my sharpshooter badge. I know how to operate a semi-automatic assault rifle. These are weapons of war. They do not belong on the streets walking around in civilian hands. There's just no reason for it. So we're working to make sure that everybody understands the terminology, and we actually have a really, I have to say, a groundbreaking CME module on this. And I'll tell you the reason it's really helpful is it's really easy for people to tune out when you ask about gun safety and gun locks and things like that at home when there is you're working with a gun owner as a patient. Having the right words, understanding the lingo, and being able to communicate effectively is really what our CME module is about. So if you're not aware of or haven't seen it, tell anyone that you think would be benefit from seeing it, because it's online and it's free. Finally, overdose deaths. And I know this has been a long focus of Alliance advocacy. It's alarming what the overdose epidemic curve looks like. Every state has seen an increase in opioid-related mortality at either the state level or in individual cities these past years. A lot of challenges in getting evidence-based care to patients, particularly those with mental illness or substance use disorder. And we continue to see inequities in who gets treatment, particularly when you look at minoritized and underserved communities. More than 100,000 Americans are dying every year from opioid use. So we've got to get rid of barriers to getting people treatment. We've got to make sure that people can access medications in ways that are safe. So we led the FDA advocacy efforts around getting naloxone over the counter, which has been a huge help. And we continue to urge every manufacturer who makes naloxone to apply for OTC and make it affordable. We have seen in our 2022 AMA opioid epidemic report a 46% decrease in opioid prescribing by physicians. We are doing our part. That is a huge drop in opioid prescriptions, pills going out the door. The problem is we're seeing a dramatic use in illicit fentanyl, fentanyl analogs, methamphetamine, and cocaine. And so while we are looking at the prescription prescriber data monitoring databases at the state level billions of times to make sure that we're doing the right thing, unfortunately, we'll work in this environment where we just don't have the right policies at the state level. So we'll continue to work on that. We have a substance abuse task force and pain task force really now working on collecting better data, trying to get rid of these barriers to getting people into treatment, supporting individualized pain care, better data around harm reduction strategies, and trying to improve our multi-sector collaborations. And I'll just mention, there was a sort of unfortunate thing stuck into the Consolidated Appropriations Act last year called the MATE Act. And this makes it a requirement for every physician when they renew their DEA license as of July 1 to have 8 hours of CME around opioid use and abuse. We opposed it. We don't think that requiring somebody to sit in front of a computer for 8 hours is a very effective use of our time. But it got snuck in there. It is the law. And so we have tried to make it easy for any physician who's up for their renewal to get the hours, track it. It's part of our Ed Hub. There's a new resource that hopefully will be a one-stop shop and helpful for folks, just for folks' awareness. So let me stop there. A lot to get through, and I have no idea how I did on time. I hope I'm okay. I just want to behalf on everyone at the AMA. Thank you for your support and your advocacy, because it is so critical on behalf of our patients, on behalf of physicians and physician families.